who is president of Muradabad Society and a very, very dear friend of mine. And I would also like to congratulate her for taking so much pain for conducting this webinar so that it reaches each and every gynecologist of India. And thanks, ma'am, for making me part of this webinar. I'm sure Anuja sitting here must be very proud of her mother. Right, Anuja? So here we are.
Ma'am, please wait. She'll be introducing you.
Okay, fine. Otherwise, these are all friends only.
Dr. Richa, please introduce Dr. Bela Bhatt. Check your mic, Dr.
Okay. So, Dr. Bela Bhatt, she is MD Obs and Gyne from MSU Baroda Medical College and consultant obstetrician and gynecologist, Rainbow Women's Hospital, Andheri East, Astha Hospital, Andheri West, Mumbai. And she is operator of Fetal Medicine and Foundation of UK. And she is managing committee member of AFG Mumbai, core committee member of Youth Mela Efficacy project. Won PCPNDT case, Bombay High Court by fighting is in person, special interest in fetal medicine, gynae, ultrasonography and infertility. She is faculty at many states and national level conferences and she is master of ceremony of several states and national conferences. So I will ask Dr. Bela to please.
Thanks, Chairperson, for kind introduction. Well, the topic given to me today is the best in the quest, double, triple or quad marker. I'm sure you all must be familiar with these terminologies, especially the triple marker, because we have been using it since years. Now that double and quadruple markers have come, we better know which one is the best out of all three, whether it's double marker, triple or quad test. The first question that comes into our mind is there a need for this test at all? We all know that these tests are basically to find out whether there is chromosomal anomalies in the fetus, whether it's commonest chromosome, trisomy 21, 18, 13, right? But then whether it is necessary at all to find out chromosomal anomalies. Previously we used to do only congenital anomaly scans at 18 weeks. That's fine. Structural anomalies are ruled out. So why so much hue and cry about chromosomal anomalies? Well, the answer is yes, because we know these days, because of late marriages, late pregnancy, career-oriented women, we get so many patients at advanced maternal age in pregnancy, beyond 35 weeks, 35 years of age. In 1970s, there used to be only 5% pregnant women who used to fall in this category of more than 35 years of age. Whereas now we see almost 20% of females who fall, pregnant females, who fall in this category of more than 35 years. And so, in 1970s, there used to be only 30% fetuses with trisomy 21 who used to fall in this category of more than 35 years of age. Whereas, now we have almost 50% of fetuses that comprise this age group. So naturally the burden of problem has increased because of increasing maternal age. So all hue and cry about chromosomal anomalies and detection is increasing because of this particular reason. We want to find out, and not only we want to find out, we want to find it out at the early age in pregnancy. So basically all these double marker, triple marker, quad marker are part and parcel of biochemical markers, which are again a part of prenatal diagnostic techniques. So these either sonography, that is nuchal scan, which I'll be talking about in brief, or biochemical markers, which are screening tests, along with diagnostic test, that is chorion-villus biopsy or amniocentesis, lead us to the diagnosis whether the baby is having chromosomal anomaly or not. Now, why are these tests known as screening tests? As I have mentioned, this ultrasonography, that is nuchal scan, or biochemical markers are part of screening tests. Why are they called screening tests? Because either of it is only for screening and not for diagnosis. This is something which is very, very important for all of us to understand. These are just screening tests. And in conjunction with the age-related risk of patient, it is useful to help determine the need for more invasive tests. So basically these tests help us to segregate low-risk population from high-risk population, and then this high-risk population is suggested invasive test. I repeat, we just suggest invasive test and we don't offer invasive test to patients. When we see that the patient is in high-risk group, we offer them, we just suggest them that now if you want to go for a definitive diagnosis, then you may have to go for invasive test, either chorion villus biopsy or amniocentesis based on the weeks of gestation, and that will give you definitive diagnosis. So that's the difference between screening test and diagnostic test. So it does not have the same predictive power of amniocentesis or chorion villus sampling. So it is not a definitive test. The patient has to be well informed before carrying out any form of this screening test, be it a sonography, nuchal scan, or double marker, triple marker, or quadruple marker. And if some abnormality is detected, then it helps us decide whether to continue the pregnancy or terminate. Again, this is patient's take. If the baby is having some chromosomal anomaly or some structural anomaly, we just have to explain about the possible prognosis, and it is ultimately patient who decides. Sometimes even a patient with trisomy 21 may decide to carry the pregnancy. So it is entirely patient's decision. If continue, then managing the remaining weeks of pregnancy, determining the outcome of pregnancy, planning for possible complications during delivery, planning for problems that may occur in newborn or infant, and finding conditions that may affect future pregnancies. That is prognostication. Now let us first understand as to what is double marker. This is a newer test. As the name suggests, it involves measurement of two hormones, that is free beta HCG and pregnancy associated plasma protein, or we call it as PAPE. So beta HCG and PAPE, these two form double marker test, which is to be carried out at 11 to 13 weeks, though it is better for PAPE to be conducted at 9 to 10 weeks of pregnancy, but usually the time limit is 11 to 13 weeks. For second trimester markers, they have to be done between 15 and 17 weeks, which include the triple marker, which is age old, and I'm sure everyone sitting here must be knowing about it, the HCG, alpha fetoprotein, and unconjugated estradiol. And the quad marker also includes inhibin A, which is a newer test. Now you must feel that this is a costlier test and why to go for this. Well, I'll come to that as to which one is better out of these two. The only important thing here I want you all to understand is that these tests are to be carried out, if at all, they are carried out between 15 and 17 weeks. Why? Because suppose after this test, the patient falls in a high risk category. What is the next suggestion to the patient? Invasive test to confirm whether the baby is having chromosomal anomaly or not. And that test is amniocentesis, which gives a routine karyotype test 21 days. So if you do this test at 15 to 16 weeks, you will get your result by 19 weeks. And we have, if at all patient wants to terminate, the legal limit is 20 weeks. So we want a result before 20 weeks. So please don't do it at 18 and 19 weeks. There's no point in doing it 18 and 19 weeks. Because even if the baby is chromosomally anomalous, we'll come to know at 21, 22, 23 weeks. When the patient can hardly do anything legally. So ideally you should do it between 15 to 17 weeks of pregnancy. Interpretation of all these biochemical markers are based on age, ethnicity, gestational weight, singleton or multiple, diabetes mellitus, smoking, IVF, and the risk is calculated and adjusted for all these factors. Now what does a positive test mean? There can be different interpretation for this. There can be nationally decided cutoff for this. For trisomy it is 1 in 250, trisomy 21. For trisomy 18 it is 1 in 100. The test can also be said positive if the risk of having chromosomal anomalies more than age-related risk for that particular patient. But to me, what is most important is the fourth one, and that is patient's own attitude towards risk. See, if you carry out any of the tests, you must have seen in the result, they give a number. the chance of trisomy 21 in this particular fetus is 1 in 1200 or 1 in 750 or 1 in 100, whatever. Now suppose the report is 1 in 750, right? Now you put it in intermediate risk or low risk, but there can be two kind of patients. One patient may think that 1 in 750 is the risk. That means there is a chance that 1 in 749 will be normal. Only 1 is affected. So I don't want to go for invasive test. There is a chance of abortion in invasive test. 1%, 2%, whatever. So it's fine with me. 1 in 750 risk is fine with me. And I don't want invasive test. Whereas the other patient may feel that the risk is 1 in 750 and what if that 1 is my baby? I want to be 100% sure. Doctor, carry out the needle test and rule out, I want the 100% result. I want to know the karyotype. And so it's basically patient who decides. Everywhere in this, all these states, ultimately it is the patient who is going to make decision. You are just supposed to explain to the patient as to what is the risk. You are supposed to give the number to the patient. It is patient's take whether to go for invasive test or not and confirm. Now suppose the report comes in high risk as per our criteria. Now what do you have to improve? Suppose the patient doesn't want invasive test. Patient says that I want to improve the performance of screening test. What else do we have? Suppose you have done a double marker at 11 to 13 weeks. You can combine it with a nuchal scan. I'll come to it because it is definitely a better combination. Or if the patient doesn't want that, in the second trimester we can go for either triple or quad. And suppose the patient has come only late and you have done triple or quad, in that it has fallen to high risk. You can go for a little anomaly scan, which you usually do, but there is genetic sonogram now, in which there are 9 soft markers of trisomy, which are also looked for to find out whether the baby is having chromosomal anomaly or not. As far as interpretation of all this double marker, triple marker and quad marker is concerned, in double marker, as I have said, beta HCG and Pepe are taken into account. In trisomy 21, the beta HCG is high, that is more than 2 mom, and Pepe is low, that is less than 0.5 mom. Whereas in trisomy 18 and 13, you find both of them are low. If you do a quad test, you will find that beta HCG and inhibin A are high, whereas rest all are low. And in case of trisomy 13, AFP is high, rest are low or normal. Now a positive test in case of triple and quad test means having a high risk of chromosomal anomalies or neural tube defects in which AFP may be high, gastroschisis or omphalocele, or multiple gestation in which again these hormones are going to be high. And in addition to Down syndrome, it also gives information of some other conditions like Turner syndrome, triploidy and some other conditions. Now you must be thinking that almost half the talk is over, but we have still not come to the conclusion as to which is the best, whether it is double, triple or quad. Well, suspense is best disclosed at the end, and so I'm still going to keep you on hold, because before we come to this conclusion, we need to know about 2 more things, which is age-related risk of trisomies and nuchal scan. What is age-related risk? We all know that with increasing maternal age, the chances of chromosomal anomaly increases. At the age of 20, it is 1 in 1527. This is term risk of trisomy 21. At the age of 25, it is 1 in 1352. And at the age of 35, it is 1 in 356, so on and so forth. So with increasing age, the chances of all these trisomies increase. The second important thing we need to know about is nuchal scan. You must all of you must have heard about it, and we are going to discuss it in detail in the next panel discussion. It is to be conducted between 11 to 13 weeks, 5 days. Not going into detail of it. We have to measure the nuchal translucency and nasal bone, and there are 2 more markers also, tricuspid flow and ductus venosus. And based on that, again you get a risk. How you get a risk in biochemical test? 1 in 1200, 1 in 1500, 1 in 750. Similarly, after nuchal test, when you put it in a software, all these measurements, you get a risk. Now this is the most important slide, which decides which test is better than which. depending upon the sensitivity and specificity of the test. If you take just maternal age into account, the sensitivity is just 30%. You include double marker along with maternal age, the sensitivity improves to 60% with 5% false positive rate. You just take maternal age and nuchal translucency, 80% sensitivity with 5% false positive rate. Maternal age, double marker, that is beta HCG and PAPE, and nuchal translucency, the sensitivity increases to 90% with 5% false positive rate. Double marker, maternal age, nuchal translucency and nasal bone, again one more marker of trisomy 21, the sensitivity increases to 94% with just 3% false positive rate. In this group we also include the ductus venosus and tricuspid flow. So overall you can say that double marker with nuchal scan, the sensitivity is 90 to 94%. You can yourself see that the highest sensitivity is with this test. Maternal age and only triple marker. Now, please look at this. You have been doing this since years. Look at the sensitivity of this test. Just 65 to 70% sensitivity. And look at the sensitivity of double marker plus nuchal scan. 90 to 94%. You want to give better result to the patient. When the test comes positive, you should be able to say with surety that there are all chances that baby is having this and therefore you should go for invasive test. You can at least suggest with surety if the sensitivity of the test is high. So with triple marker, the sensitivity is just 65 to 70%. It's almost the time that it becomes obsolete. Triple marker is not to be done. If at all you want to do, go for quad marker, which is 81% sensitive. Quad test, little expensive, but the patient need to understand. They need to realize that they have to go for a more sensitive test. An integrated test in which we take into account first trimester PAPE and second trimester all triple markers. So total 4-5 markers. Sensitivity is 91%, but again it is little late in the second trimester. So out of all, I don't need to tell you which is the best test now. I think you know for sure that which is the best test, and that is double marker with nuchal scan, which is known as a combined test. So it is a combined test which gives you the best sensitivity with least false positive rate, and so it's a clear winner. Why? There are reasons also for the same. It is a non-invasive test. Sensitivity is highest, 90 to 94%. Result is provided at earlier gestation. It is 11 to 13 weeks, first trimester. So there is enough time for decision making for patient, whether to go for a better screening test or whether to go for invasive test. Some structural anomalies can also be picked up as early as 11 to 13 weeks. There are many anomalies which can be picked up. So, if at all some abnormality is picked up, early and safe first trimester termination is possible as compared to second trimester termination. In case of doubt, if only one of the two is high risk, then patient may go for second trimester markers and anomaly scan or genetic sonogram for improving the screening performance. Suppose you say that we want to do double marker and nuchal scan and everything, but the patient only comes late, 4.5 months, what to do? Then there are two options, but I think you know which one to go for now, right? Not triple marker at least, right? Because the sensitivity is just 65 to 70%. If at all you have to opt between these two, please go for quad test and not triple marker. Oscar test, this indeed needs Oscar as far as fetal medicine is concerned. This is one-stop clinic for assessment of risk, though not every lady is ready for this. But this is the latest prenatal screening program for Down syndrome introduced from Fetal Medicine Foundation of UK. It is conducted between 11 to 13 weeks of gestation, where double marker and nuchal scan are done, and those who fall in high risk are suggested Korean villus biopsy. Those who agree, they conduct it on the same day, and within 24 hours they get the result. So within 24 hours the patient comes to know whether the baby is having chromosomal anomaly or not, and the detection rate is as high as 90%, which is now routinely performed in UK. Still it will take some time here because the patient acceptance is not so high. Plus we don't get result on the same day. Even if we go for fish, we get result after 5 to 7 days. As far as the future of this is concerned, use of fetal cell DNA in the maternal circulation for prenatal diagnosis, and which may negate the need for coronary villus biopsy and amniocentesis. But again here the PCP&DT issue comes, especially in Maharashtra we are not allowed to do NIPT because of the PCP&DT issue. And the second and very important thing is cost effectiveness. This costs almost 30,000 to 35,000. So again in India it is not all that feasible. So what we have at present, and out of all, I suppose you know which is the best, the double marker with a nuchal scan, and if patient falls in high risk, along with invasive test, you can reach to the diagnosis whether the baby is having chromosomal anomaly or not. Thanks for patient hearing. Thank you.
Thank you, ma'am, for very informative talk. I think Dr. Kumkum wants to ask some questions.
Ma'am, please highlight some medical legal issue if we don't get it done, or sometimes when
See, basically we are supposed to offer this to each. See, it's not that we have to offer it to high risk patients only. No. Screening is meant for entire population. So each and every patient coming to you in the first trimester, you should sensitize. Right from the 5 weeks, 7 weeks she comes, you should tell that these are the things. In fact, those who are educated, little educated, even if you tell them at 7-8 weeks, please go and Google what is nuchal scan and what is double marker. They'll go, they'll read, and they come back, yes ma'am, we want to get this done. Right? And if not educated, you have to sensitize them. See, these are the things that we have to offer to you. Whether to go for it or not is into your hand. Whether it is financially possible for you or not is in your hand. You can put it on paper. Because these are the
combined test is 90% sensitive. But then the sensitization should be for the 10% also. Those who are doing, and sometimes 10% can be missed. The patient should be sensitized for that also.
That's what. Whenever we do any screening test, we tell the patient these are not diagnostic tests, these are just screening tests. And if at all you want a 100% diagnosis, you have to go for an invasive test. That is something which has to be stressed upon.
Pre-test counseling.
Yeah, always counseling is the most important part of it.
Okay. Thank you, ma'am.
Thank you.
I request Dr. Kumkum Mehrotra to present a memento. I request Dr. Richa Gangat to present a memento and certificate to Dr. Kumkum Mehrotra.